Good morning. Feelings of fear, despair, concern, ethical dilemmas, death, watching patients with breathing difficulties struggle to breathe, absence of family, visitation policies, eating restrictions, chaplain services, supply concerns, masking, Zoom fatigue, disparities, and then hope with the introduction of the vaccine. Good morning. I am Dr. Gloria McNeil, and I am a proud nurse. I am here today with member nurses from the Duke Regional Hospital. It is my esteemed honor to share the stage today with these amazing, dedicated, and awesome nurses. These nurses are a few that represent the many, many other nurses, not only within the Duke system, but throughout the nation and the world. In the words of Florence Nightingale, my colleagues here are great examples of nurses who devoted themselves to the welfare of those committed to their care. December 2019, March 2020, are dates that changed the healthcare landscape and a major change for those of us in healthcare, and specifically nursing. We had to pivot and adjust to learning about COVID-19 in real time, change what we had been taught or what we believe to be evidence-based, and at the same time protect ourselves, each other, our family, and our loved ones. We were faced with the reality of many losing their lives and loved ones. The impact was great, not only to what we were seeing in the hospital, but also many of us had family members who were also impacted. The world was on hold, doors and businesses were closing, churches and schools were closed, and we nurses, we were still coming out into the world doing what we were committed to do and called to do, while many were afforded the opportunity to work from home. We were glued to the television, and we were getting good and bad news and information. The political landscape was playing out, and we recognized and understood that we had a major public health issue. It is no wonder that nurses continue to be the most trusted profession as identified by the Gallup organization. Nurses ranked most trusted profession for the 20th year in a row, with the exception of in 2011, which is understandable, the firemen had that spot. So it is my absolute honor and privilege to introduce to you 6 amazing nurses from Duke Regional Hospital. We have Dr. Faith Waters, who is the Clinical Operations Director, and she led both the critical care and the medicine unit where we house the majority of our COVID-19 patients. We have Amelia Wright, critical care nurse, and she was a nurse leader in our critical care unit. Ms. Megan Smith, one of our now newly assistant nurse managers, previously charge nurse on the area where we cohorted our COVID patients in the inpatient area. We have Mrs. Uma Kay, who is the nurse manager that led the COVID unit, as well as most recently our critical care area as well. And then we have another amazing nurse, Melodi Langolis, who is the charge nurse on our COVID unit. Also, I want to thank Dr. Gwen Wright for inviting us to participate when she first reached out to me, I was hesitant. And she asked, well, I just want the nurses to tell their story. And I'm like, well, we do what we're supposed to do, and this is what and we're still in it. And so with some persistence, she called me again or emailed me again, and I reached out to Dr. Waters, and we said, yes, we need to tell our story. It's important that others understand what we've been through. So I'm going to pretend to be, I like to say Oprah, okay? So I have these amazing nurses here, and so we're going to do a panel, and our first question, I'm going to direct it to Dr. Waters, and I'm going to ask her if she could just describe for us what it was like for nursing during the pandemic. And I just want to put a disclaimer, we're still in it. So, so it's not over, okay? So Dr. Waters, if you could just share with us, as a leader, what was it like for nursing at that time and currently?
I think for me, knowing that my areas of coverage include the medical units as well as our intensive care unit was, oh no, this is coming to me. Because at some point or another it was going to end up on one of my areas. And so really trying to look at what was the first thing to do and to figure out where it went, who was going to take care of it, what were we going to need to do. So I think we started meeting, I would look back at my calendar. The first meeting I saw on my calendar was January 29th, 2020. When it was our first meeting, we had to talk about what are we going to do because this is coming our way, sure enough. And so we started getting together to look at what would we need, what would it take, where was it going to go, and really understanding the impact it was going to have on us as a hospital, as nurses, and as a community, because this was not just going to stay within the confines of our building. So it was the opportunity to really listen, as I wrote down, and this is really not any good, but anyway, but we started listening, watching, learning, starting in December when we first heard about this coming, knowing how widespread it could potentially be. But I don't think even as much as we tried to take a good offense instead of being defensive, we still were not really prepared for how it came and when and how fast and how hard. And the impact that it had, not only on the patients we were seeing who came in, and we basically said, you can come, but your family can't. So we locked out the visitors. We locked out their family support. We taught our nursing staff, this is what you have to do. We told them what they could wear, what they couldn't wear. You have to mask. What do you need? We shut down any ancillary services or extraneous, if you could call it that, activities within the hospital just to make sure we could focus on what we had to understand the full impact. And so it was isolating in and of itself because we didn't know what was going on. Nobody else did, and we were shutting everybody that didn't need to be in the hospital out. And so the impact that had on the patients, on our staff, how do we allow them to communicate with family? Because we know that's a huge thing. Families didn't know what was going on. How do they know? How could the nurses see the patients? And the time it took to don and doff and dress to go into these rooms, and do we have everything we needed? So we started looking at all of these things to figure out how we could preempt and plan for what the nurses needed. And it still came down to really just taking that step back and asking the front line, what do you need? This is what we think it is. And what do you need, and how can we help you? Mm-hmm.
So Dr. Waters, you mentioned don and doff. Exactly what is that?
So donning is the term we use how do you put on your PPE? So how do you don your PPE, which for us, for COVID patients, initially and still does, consist of an N95 mask. We wore gowns. We started off with the staff were concerned about what was going to be on the clothes when they went home and were they going to take this home. So we got scrubs so they didn't have to wear their own uniforms inside the patient rooms. So that donning, again, they would come in when they came to work, change into hospital supplied scrubs. Prior to going in the patient's room, they had to, of course, wash their hands, put on their masks the right way, put on their gowns the right way, put on the face shields the right way. And knowing and wanting to make sure they did that correctly, we have what we call personal protective equipment observers, or PPE observers, that would actually watch them to coach and make sure everything was correct to minimize their exposure to COVID going into the rooms. And then coming out of the rooms, we had to doff or take it off. We also wanted to watch to make sure they didn't contaminate themselves or anything else as they were taking it off, again, to minimize the spread, to control what we could control.
Okay, thank you, Dr. Waters. So now, Nurse Amy, what was it like for you as a nurse in the critical care unit caring for or responding to the COVID-19 pandemic?
Well, it was difficult for sure. I think talking about this now, it takes us all kind of back to the beginning. And that was a time when we really didn't know anything about what was going on. As Faith was talking about the PPE observing, I was sitting and thinking about just how careful we had to be because we had no idea what it would take, how much of it would take for us to take it home to our families. And I remember not only did we have to be careful with the patients, but we had to be careful with each other. And so one of my fondest/saddest memories is looking at two nurses hugging for the first time in a month. And they were able to do this by gowning up, putting on all their full PPE, and we're talking boots, we're talking a gown, we're talking head covering, masks, gloving. These two nurses were actually in PAPRs, which is that whole like spaceman suit looking. And we were able to watch them hug through a window. And it was the first time we had seen that in a month. And it was just a very powerful moment.
Okay. All right, thank you. Megan, what was it like for you?
Well, it was an experience. I remember we had about 24 hours to prepare our unit from the time we were told we were going to be the designated COVID unit to the time that we got our first patient. So in that 24 hours, it was a whirlwind. We were learning about new policies, new procedures, new practices, how to don and doff this personal protective equipment safely, how to care for each other, how to take care of these patients, what kind of symptoms and signs we need to look for. We didn't know what to expect. Also, too, being in the role of charge nurse, I'm doing assignments, I'm doing staffing, figuring out how we're going to staff to take care of these patients. Coming on as the assistant manager, now we're looking at budget. How are we financially going to fit this into our unit? Lots of practice changes, how the patients are transported, the restriction of the visitors. As nursing, we're very compassionate, and we think about, the loved one is there at the bedside with the patient. Now that's taken away from them. So we are the support system for the patient. Something that we did on our unit for one is we requested windows to be put in our patient doors. So with those windows, we were able to visualize our patients. That's something that is different from other units of the hospital. So our patients felt more connected to us. They could see our faces, more so than those big PAPR devices that we had to wear. So that's one of the things that was great that came out of it. Another thing is we implemented iPad devices to be able to call patients' loved ones. It's sort of like a FaceTime type thing, so they could see their loved ones. We would put those on stands and set those in front of patients so they could communicate with each other. It was scary. Every time I went into a patient room, I would think to myself, I'd have to stop and take a deep breath. Is this the time? Is this the breath I'm going to breathe and get COVID? Every time I drove home from work, is this the time I'm going to take it to my family? And then the vaccine came in December, and what a moment of hope. Hope for our community, hope for our patients, hope for our hospital and our nation. And it was a time where I could see that we could be together, and being here in this setting with you all, it's such an honor, and thank you for having us.
Yes, all right. Thank you, Megan. Uma, as the nurse leader leading the unit, what was it like for you, and what did you experience?
I think for me, the moment I found out we were going to be the COVID unit, I took a breath. I had to just stop breathing for a minute and regroup. From an education and training standpoint, I had the confidence to be able to move the unit in the direction we needed to. But my focus and my concern were my staff and my patients. How do I keep my staff safe first, and how do I keep them resilient, and then how do I take care of my patients to the best of our ability? 4-1 has an awesome team, and they have continued to step up to the challenge and continue to take care of these patients to the best of their ability. But one of the things I think I discovered is the power of we, and we being not just 4-1 and not just the division line, but we as an organization all came together so that we could take care of these patients. It was one of the most difficult assignments I think we've had. I think that the support we got from our ancillary services, infection prevention, our respiratory, our providers, our materials resource distribution, our employee health. My goodness, we were in contact with them almost on a daily basis in trying to make sure we understood the needs not only of the staff and how to keep them safe, but how do we take care of these patients behind these doors where no one had an idea how to take care of them. I was constantly on the CDC website trying to see what was new or what was upcoming so I could speak to it. But the amount of collaboration that developed from us being a COVID unit was astronomical. We all learned together. We all made the mistakes together. We all realized what were best practices and what weren't. What we did the first wave, we didn't do the second wave. What we did the second wave, we didn't do the third wave. And so that was an amazing team effort. I think the hard part was, making sure that I checked in on my staff on a daily basis as well as my patients, right? Not only from an education and training standpoint, but from an emotional standpoint. How are you doing at home? How are you managing? The stories of, I moved into a hotel because I didn't want to take a chance of my kids and my family getting it, were very real, right? And the separation from family, separation from parents, right? I tell a story about my kids are grown, but I call my vet because I didn't know what was going to happen with my dog, right? Who was going to take care of my dog and what is the transmission, if at all any. So I think from a day-to-day basis, an operational standpoint, it was ever-changing. What we were doing in the morning, we didn't do in the afternoon. And this staff learned to pivot, as Gloria said, on a very quick basis. But we do that, right? We do that as nurses, and we do it well. One of the things we don't do well is take care of ourselves from an emotional and psychological standpoint. So making sure that reaching out to our nurse leaders to see how we can support them, whether the use of chaplain services or our employee health, what kind of resources do we have for our staff?
Right, thank you, Uma. Melodi, our newest member to our nurses team, she came in right as the pandemic was beginning. So from your perspective, what was it like for you?
Well, I graduated in December of 2019, went off with my daughter. We graduated together, went to South Africa, came back not even thinking about COVID, and started in February when COVID just really was coming onto the scene. And I didn't know anything better. So when I started, PPE, COVID, it was my normal. I didn't, it was challenging, it was exciting, it was scary because I didn't know. But 4-1, where I work now, was there for me all through till now as a very supportive team and teaching me the ways of the road. COVID with the patients, it was hard. One of my first patients that passed, I was in the room by myself because no one else could go in the room. No family, just me, and it's daunting. Yeah.
So what kept you going or motivated? I'd like to take that question.
My team.
the team?
Like you were saying, everybody kept showing up. And so we showed up for them. I think I can't say enough about how amazing these people are and were, and what that experience was like. And it was like, I've never been in the military, obviously. I've never been in a war. But it was, standing elbow to elbow, fighting something every single day. And trusting the people next to you with your life, because those were the stakes. And seeing, there's no way, I'm stumbling here, but there's just no way possible to not rise to that when you see people near you doing that.
What type of resources or support was provided to you and others?
So I know in the ICU, we have historically had almost like a support group called Real Talks, because working in the ICU is hard anyway. It's a challenging job. We deal with a lot of death. We deal with a lot of ethical issues traditionally. COVID just took that to the nth degree. So we had that kind of support group already set up. Unfortunately, we had to start meeting by Zoom, and then we were so busy and working so many hours that we weren't able to do it as much as we would have liked to. But we did have our chaplain services who were amazing with their support. We have the personal assistance program where we have access to therapy through our jobs. We had you guys who came and checked on us and really wanted to know what you could do, wanted to be there for us. And I know that it was probably a powerless feeling. I know I felt powerless for the people under me, but the intent was there.
Melody, I understand that you had a unique way of dressing to help motivate your staff. Want to share?
So,
A little birdie told me that.
yes, I go to work every day and I have my blue scrubs, and then I only wear red shoes. I only wear Wonder Woman socks. Some of them have capes. I wear a Wonder Woman headband. My badge reel's Wonder Woman. My fanny pack is Wonder Woman. So my glasses are red with Wonder Woman on them. And people come up to me at work and go, I don't know your name, but you're Wonder Woman. So it's lighter for patients. I don't know. We're talking about what got you through, and for me, it was teamwork. Coming to work and having our morning huddle and knowing that we're all in this together, and once you go into a room and you're all covered in your PPE, you're not coming out every 5 seconds. If you need something, you need to call for help. And everybody's busy, so you have to be patient, but you know that somebody's there for you when you need them.
I just want to expand on that one moment. Okay. Melody mentioned the words, we're all in this together. On our unit 4-1, we made a bulletin board. We had handprints. We cut out hands for each person, and we wrote our names on these. We pasted them on this bulletin board that said, we're all in this together. Every single nurse, every single nursing assistant, unit secretary, unit leader, we were in this together, and we are still in this together. Our team got us through.
I think one of the things we'd be remiss in saying is that when we try to look logistically where this was going to go, wasn't that we singled for one out, but just logistically it made sense to land there. But this unit was, I think the most experience we had there was probably a 5-year-old nurse. So this was a new nursing unit. our intensive care, we had a lot of new grads. We probably were at about a good 30 to 40% new grads versus experienced nurses. And so to put this type of population on this level of nurses and for them to rise to the occasion and handle it with the dignity and grace that they did was truly amazing. So yes, you were a Wonder Woman. And you set that example for your peers, and you lived up to it, and so did they. So we thank you from the bottom of my heart for everything you did, because I don't know that our patients would have had the outcomes they did had y'all not taken the onus of it like you all did. So I thank you for that.
Yes. Okay, so how do you, or did you move forward? How did we make it through this as nurses?
I think from my perspective, again, learning from each other, leaning on each other, trying to figure out what was next. As Uma mentioned, each wave was a little different, so whether we learned from this one that we apply to the next one versus the next one. I think we had the opportunity to engage in some of the research studies that were being done that kind of helped us prepare. So we felt like we were helping the cause, trying to identify solutions, so that I think helped us continue to move forward and to see the light. And I remember when we first got the vaccination, nurses were in tears. They were so excited to have it. So again, so to know that there was still movement forward to figure out how to, if at all possible, contain this, to treat this, to protect ourselves and to protect our community as well as our patients. So I think that's one of the things we held on to as we continue to move forward and figure out what next do we need to accomplish and challenge.
I think, too, part of moving forward is acknowledging where we've been and what the journey to this day has been like, and what do we need to do in order to figure out some of those gaps, where we could have done things a little better. How could we prepare for the next pandemic? If we start today, sorry, maybe we'll be ready by that time. And also to, understand what some of our wins are, what some of our losses were. Again, we had a great support from our organization. The windows meant the world not only to my nurses, who now could visualize their patient, but also to the patients who could see out into the halls as well. We asked for gowns. We went through many versions of it before we found the gowns that we needed. So just support from an organization that just never gave up and looking for the best way to support its employees and take care of our patients.
And I think we'd be, again, remiss without acknowledging the one group that's not represented here is our emergency department that were very much frontline because they got it and they sent it to us. But also our supply chain. We had a wonderful supply chain manager that I don't know how she managed to find stuff, but she found stuff so we never ran out. To Uma's point, when we needed something different, she found it. And for our health system for being willing to support and saying, not how much does it cost, but what do you need? And going without, fail to find everything we needed. We talk about the windows and doors. It may be a small thing, but it did allow patients to see faces without masks and hoods and gowns. For that few minutes to have that connection, it also allowed them to see that, yes, they are coming. I'm having trouble breathing, but I know they're right there. They're coming in for just a minute. And everybody that was involved in everything that they did to help us to be able to get there. So, again, learning from that, moving forward, and how do we apply this to the next pandemic that we hope will not be to this magnitude, and now the endemic that we currently have with COVID. So it's still here, and we're still living through it, but how do we continue to move forward?
There was a mention of the vaccine, and I also understand that several of you went out into the Durham community to administer vaccines. Any one of you want to share what that experience was like?
Well, I did a couple of the vaccine clinics, and it was very rewarding, one, to see the community come. Some of them scared of needles, but willing to take that vaccination because they felt it was the right thing to do. And the appreciation that was shown, we did, as a hospital and a health system, we sponsored several community drives where we tried to take the vaccination to the people that needed the most. So we made sure we went into the African-American communities, we went into the Latino communities. We took the vaccine where it needed to be given. Instead of waiting for people to come to us, we went to them. And it was very well received. I don't remember the total number of people we vaccinated. We took over Southern High School cafeteria as a vaccination clinic. When they decided to open schools back up, we took over Wheels as the vaccination clinic. It was like, okay, we're next. We went to churches. We had mobile drives. So we just did a lot to vaccinate the community, and it was very well received.
I understand there was even vaccination in the pews at one of the churches.
Yes, we did. We went to churches too.
Yeah.
So definitely, we're willing to go wherever they would have us and wherever it was felt we were needed to be.
Melanie?
I'm just thinking we should talk about the wins and
Yes,
how.
the wins.
And how somebody who would come in and they were so sick and end up in the ICU, but then they would come back up to us on 4-1 and they would go home. And that was so rewarding for us, and it just got you through another day seeing that somebody else was going home rather than not, because it was hard when they didn't make it.
You know, I remember taking patients out to their cars after discharge. You know, they'd been with Amy in the ICU for so long. Many of them complicated stays. Come to us for, you know, additional, I'm talking months. You know, they had been with us, had gone through treatment. And just taking that patient to the car was the first time they had seen their loved one in weeks or months. And, you know, the embraces that they had, the emotions that they shared with one another was so rewarding for me as a nurse to see that I was making a difference, that I was making a difference for this patient and their family, and that they could go home to be with them again.
Yeah, because when we would do, when people would leave the ICU, we would line the halls and clap them out as we rolled them to these guys. And then, I think you guys did some similar when they would leave y'all. And then, wow, when you actually leave the hospital, it was, everybody got on board. Because we were just so thankful to see it, because you didn't see it all the time.
A win for us was when we had a COVID patient whose birthday we were able to celebrate with a little cake from Food and Nutrition. You know, their family couldn't be there, but we were their family for them. And they were trying to keep in touch with those everyday things that mean so much to everybody.
Something that meant a lot to me as a nurse caring for these COVID patients from our organization. Every Friday at 10 a.m., the hospital operator would announce overhead. I forget the exact wording, but they would announce how many discharges we had successfully discharged of COVID patients. So seeing and hearing that impact that we were having really, you know, kept us going.
And we did, on Fridays we have a tiered huddle where how we communicate. We also acknowledge those that we lost and had a moment of silence for them and their families, and also the staff we took care of them. So we tried to make sure we acknowledge the wins and the losses. But it was very rewarding when we started seeing the wins outweigh the losses. And the number of patients that actually got to go home, that some of them we didn't think would. And so it was very rewarding to us to see that happen as well.
Anyone else? Thank you very much. At this time, we're happy to address any questions that anyone may have.
One of the mics, I think. Questions?
Thank you once again for your service. So I haven't been in a hospital in so long, thank God. So you know hospitals have the appendectomy unit, giving birth unit, broken leg department. Well, you know what I mean. So did your hospital change the whole strategy of like, no, if you have a sinus infection, please go someplace else? Or appendectomy, I guess you have to let them in. But hip replacement, did you delay that? How did the whole structure of your hospital change? And did you pull a bunch of the hip replacement nurses and doctors to say, you're not doing that anymore, you're going to come over here to us, to COVID?
We did all of the above.
You know what I mean?
So one of the things we did was when we first tried to understand the impact of it. So the first few cases, no, we didn't stop everything. But when it started growing, we had already had identified opportunities for where we could scale back, change things. We did stop all elective surgeries that were not urgent or emergent. We still obviously did the emergency cases. So we stopped the elective procedures as much as we could. We delayed those. 4-1 was a medicine unit, so we just shifted their other population that was non-COVID off to the other medicine floors. But we had to continue to operate. Babies were still going to be born, people were still going to break hips, and people were still going to get sick. But we did decide on how we control what we could control, and some of that was elective surgeries. We also looked at what staff that was and what services could we scale back on. So we had what we call, we sent people to the auditorium, and we had our pool of people and resources, and we identified what those resources could do to offset the units that were taking care of the patients. So some of them were trained to be the PP observers, to observe how people donned and doffed their equipment. Some of them were runners to get this or that. So we realigned them based on their skill set to figure out where else they could help and fill in. And I'll have to say that everybody stepped up. We had a few people that couldn't, because of their own being immunocompromised, go into those areas, but they filled in other places. As a leadership, we did what we needed to do. They might have been scared for us to do some patient care because it had been a long time, but yet we were willing and we were able to be resources for them. And so we did redeploy staff as much as we could. We cut out anything we could delay safely. But we did all of the above. We also tried to make sure we have one ICU, so we couldn't take all the non-COVID patients out of ICU because it was the only one we had. So we had to figure out what side was going to be COVID versus what side would not be, and how do we draw that line to make sure we didn't have any cross-contamination or any concerns about that. So we looked at all of those from that perspective.
And to your point, yeah.
Did you have something you wanted to add?
Oh, I was just going to say, to your point about the nurses and redeploying the nurses, am I on? Okay. There were only so many critical care nurses. There were only so many people trained in what we do. There were only so many nurses trained to take care of COVID. Because 4-1 became very specialized because the acuity they were seeing was phenomenal. So there was a small pool of nurses that could actually do that work. So when they would redeploy, these people, bless their hearts, came in, were learning on the job, were willing to, do whatever, support us in whatever way, so that we could spread ourselves out and take care of more patients because the patients kept coming. So.
Did your shifts increase too? Instead of a 10-hour shift, they said, you're already here, you need a 15-hour shift?
So that was never mandatory. But it was never mandatory, but once you're there, and again, once you're there, you can't just leave because you're needed.
And we do 12-hour shifts, but at the same time, like Amy said, if the relief wasn't there or they were very willing to stay over until the next shift was okay and comfortable to be at a good spot for some people to leave and go home. I know people picked up extra shifts because they were very concerned about their peers and do we have enough and do we have all the right people in the right places. So again, they were the team and they took care of each other. and it was reciprocated by other members of the whole hospital team and across the health system as well.
There's a question over here.
Actually,
Yes.
I think I have the mic.
Oh,
Okay.
I think I have the mic. I'm sorry. No, so I don't usually try to speak for everyone, but I think we collectively have tremendous admiration for your skill, your knowledge, and your empathy. So thank you so much. You know, as somebody who's been exposed to the hospital system for a number of times, I've become well aware that the folks who have the real knowledge in the hospital system are the nurses. So thank you for that. But I was curious, I'm certain that, I don't know if any of you have actually experienced the disease, but I know that there has to be a number of people who are your colleagues who have. And so I was curious about what's the difference in terms of dealing with patients who are actually healthcare professionals who have gotten the infection versus those of us who basically come in off the streets. So that was my question.
Well, one, if it's a peer, that made it harder because, you know, that was one working next to you last week and now they're in the bed in front of you. And I think from the, I didn't have it, I haven't had it, and I pray I don't get it, but I think just that overwhelming fear of like, oh my God, that could have been me. That could have been somebody else. And I think recognizing how vulnerable you are in that situation, so it gave you a greater empathy for what the patients and their families went through.
Yeah,
Yeah.
that's why I was.
Yeah. Oh, you want to go ahead? No, go ahead.
We did have, you know, one of our nurses in our unit. That happened a couple of times, but this one time, we were able to, it was scary for us. We were worried for her. But more importantly, it was terrifying for her. This person was in a room where we lost our first COVID patient, and she remembered that. But we were able to learn so much from her because she was able to tell us what that felt like, what it felt like when people were staring at her through the window, how isolating it felt, how lonely she felt, what it was like being that sick but not being able to be around her family. And so where we all kind of knew that intellectually, to have those conversations with her really brought it home. So,
And the other thing that she did was after, in her recovery phase, she came back and started a support group for healthcare workers who had experienced COVID. And she did that on her own with much support.
it's pretty amazing.
Hi there, my name is Pani Unava and I'm a friend of Professor Darity. I come from a very small rural state in the Northeast. I come from Vermont. And so the thing is, which is every week or every other week, they would have this, our health commissioner would come on and tell us what's going on. And I'm very proud to say that he always acknowledges the help they got from the healthcare professionals, and he would always talk about the nurses. So the number I wanted to quote with you is, we had a total infection of 144,000. That's about less than a quarter of our population. But the deaths we had, as far as COVID-related, as of yesterday, I think it was under 745. So the highest marks needs to be given to the professionals like you. And my heart goes out for you. And thank you so much for being there. Thank you.
Thank you for that.
We have one here and then one here.
I would just like to say I'm from Georgia, Atlanta, Georgia, and there is such a dearth of doctors and people in the medical field that you are doctors. In so many cases, you have to act as doctors. And I want to know, how do you feel about training others in midwifery. I think that's what they call it. And people in Cordele, Georgia, Thompson, Georgia, Cordell, outside of Atlanta, they have no medical facilities. And I was just concerned. Don't you think they should train more people? All people can't go to nursing school or medical school, but you have the knowledge, and people need this help. We read about it every day. And I want to know, how do you feel about training others, whereas they could have the dignity, the respect, and the professionalism that you have?
So, to your point, there is a major nursing shortage, but the question that I hear you asking is, should others be trained that could help provide care, specifically in rural areas? And the answer is yes. And then also, we in nursing, we're having to look at alternative staffing models and ways to provide care, because there aren't enough of us to go around. The nursing schools are not able to enroll students because they don't have faculty. We're not able to hire the number of nurses that we need to take care of patients, not just within Duke, but across the nation. So we're forced to look at that. But in terms of midwifery, that is a model that we support, and at our hospital, we do have midwives as well. But your question is, should midwives that be available in rural areas? And the answer is yes. The answer for how to increase that enrollment and get it there, I don't have that. Yeah. So, but I do support the need to have healthcare resources and for all. Mm-hmm. In rural areas, yes, ma'am.
Yes. So it's apparently, from what I understand, it's harder to get primary practice physicians out into the rural areas. So what we are kind of trying to do as a profession is we have advanced practice nurses. And those are, they don't like being called mid-levels. What's the word? They're advanced practice nurses who have extra training, like your nurse practitioner and things like that, and clinical nurse specialists. What they can do, it's unfortunately it's state by state right now, but ideally those nurses would get full practice authority. Right now in a lot of states they have to practice under a physician. However, if they can get full practice authority, then they can go out into the rural areas. They are historically more apt to go out into the rural areas to treat people. And so that is a really viable option to get health care out into those areas. And we have House Bill 149 that, if it passes, would give advanced practice nurses here in North Carolina full practice authority.
Okay.
All right. Ladies, I have the utmost respect for what you do. But I want to recognize that you all are people too. And so I'd like to ask, because this pandemic and now this endemic has placed a tremendous toll on you mentally as well as physically, I'd like to ask, what do you do for your self-care?
I'm going to laugh at that for this reason. So on top of our pandemic, and just prior to that, my husband became ill. So my idea of self-care was to go back to school and get my doctorate. So I'm like, okay, so really this is when you want to do this. And I just started right when the pandemic hit, and it was like, do I stop or do I keep going? But it was also the one thing that I could own for me. So I stayed with it as hard as it was because it was mine and it was something I could do for me. So that was one of the things that I did for self-care. Crazy as it sounds, yes, I did it. But again, it was just one opportunity that I had.
And the other thing that we did, and we consciously did this, was we recognized that as we were, Faith and I worked very closely together. So one of the questions that we would ask, okay, what's going well, what's not going well, what are you doing for your well-being? And we started out with that question first. What are you doing for your well-being? And so as she was contemplating, I'm going to tell this, all this is going on, and I think I'm going to put school on hold. No. This is for you. So we were helping to support each other, and she made it through.
I have to talk about things. I have to get the opinions of others, so I leaned on my nurse manager, Uma, every day. I still do, as well as my peers, my nursing peers, because they could know and understand the emotions and things that I was feeling, but I was not able to express. And it's still hard to express these emotions because I've in a way buried them away and tucked away and learned from them. But talking to others got me through, and leaning on my team is what got me through.
And we ate a lot of food.
We did.
Yeah. Instead of the COVID-19, I gained the COVID-50.
The community, they were very good to us.
They were very good.
Yeah, this has been such an incredibly important, illuminating, and moving session. So I just want to, as others have, thank you so much. I think I've learned more here than in almost anything I've heard about the pandemic and its experience. My mom was also a nurse, so I have that connection. But I was thinking about this theme of the pandemic divide and how inequality in America made the pandemic so much worse than it, might have been. And so I just wonder, as people in the front lines, and particularly maybe some of the frontline nurses too, like if you have thoughts about, what we need going forward. Like you mentioned this particular bill just now. I've done some work with National Nurses United, and I know they're pushing hard to say, healthcare should be a human right in the United States as it is in other countries in the world, or that, we need to have a national response instead of that crazy federalist response we had for a while that put states in competition with one another for, necessary things like PPE, or, you were just talking about training, but are there things that you think of from what you've seen and experienced that can help us think about what a policy agenda should be going forward, and what, you've seen from your experience that others might not know about, but that we should really start looking into and working for? I would just love to hear your thoughts, and I imagine others would too.
I'm just going to say I'm from Canada, so I find healthcare here, the inequality is overwhelming. Everybody should have access to healthcare. During the pandemic, you did see the divide. Financially, it's just unrealistic for so many people to get healthcare. I don't know how it's going to change here if it's always going to be for profit. As for DNPs and FNPs and getting autonomy to practice in rural communities, I think that's something that needs to be pushed forward as fast as we can, because so many people are not getting the treatment they need, especially in the African American community. I find it appalling how many patients I see who have the trifecta of hypertension, hyperlipidemia, and diabetes, and the mismanagement of it, and the lack of treatment and education. There's so much more we can do, especially getting out into the community to educate. So I'm working on my way there.
This is Sandra Trejos, Professor of Economics. Thank you for your input, and thank you for sharing experiences. You said that you made a point to go to the people's houses, especially, I'm guessing, the most vulnerable. So you were the people who were really there with the most vulnerable when no one could be with them because we were isolated. So yes, from an economist perspective, but from a social point of view, from an economic point of view, what did you see? What did you experience? I'm talking basic needs, the mental and the physical health beyond doing the vaccine, because I know your training is beyond just taking care of vaccines. You take the whole individual. So what did you sense, experience, so that no one else saw, that you could share with us, that made it obvious that they were in need not only of a vaccine? Thank you.
Our president at the time, Katie Galbraith, was working with the city of Durham, and she was on I think it was a COVID response team. And they used data to identify where in Durham there was opportunity for services. And so they identified, I think it was the 27707 or 3 zip code, based on the information they had, and that's where we set up clinics. Additionally, they had, there were different clergy who were also on this team with her, and they opened up their churches in vulnerable areas, as well as work with the Latinx community to go, it was downtown and then another church. But what we saw and what we experienced, which was very rewarding, was people happy, as Faith said earlier, to get a shot, and that we were coming to them. And so, and it was, I mean, we had large African-American population, we had Caucasian, we had Latinx, but we went to where the people were. And so my answer is, I experienced, and probably I was proud of myself because I hadn't given a shot in probably 30 years. And I'm gonna be honest, and so one of the nurses, you know, did a return demonstration with me. And so I probably gave over 250 shots, and I'm real proud of that after 30 some years. But people were happy to get that vaccine. Yeah.